Good. Hello, everyone. Welcome to RLR. It's funny when Reza and I record RLR for RLR CP solvers, he always gets to go, and I feel like we have our roles reversed when we hang out on VMR. But he's on his way and will be joining us shortly. It's great to see so many familiar faces, especially those of you who have the ability to turn your video on. It makes it so much more intimate and personal when we all hang out here together. But we're very, very excited today because we have a return of a master case presenter who bamboozled us a month or so ago. Before I pass the mic to John, I want to celebrate our first-time scriber, Francisco. Welcome, Francisco. How are you feeling?
Yeah, nervous. No, but I'm excited. All the team is here. I'm sure we'll have a great case, and let's do it, guys.
100%. No, yeah, we got your back, and it's funny to see the roles reverse because you were bamboozling the scribe when you presented it. Now I think you'll see what it's like on the other side. But anyway, John, welcome back.
Thank you.
Nice
Thank
to
you.
see you. I think for the folks who did not cross paths with you when you presented before, do you want to tell them a little bit about yourself?
Sure. My name's John. My friends call me Cloud. I'm here in Baltimore. Trying to figure out this residency stuff. I presented my first case a couple of weeks back, maybe a month back. Had some fun, got addicted. Now I'm back again, and we'll be coming back.
That's a very precise summary of how I feel about VMR. Kind of put it together, got addicted, and have been stuck here. So I hope you follow a similar path. It's really, really cool. Yeah, I think, let me just check on Prof. Rez. He said he'll be here in a couple minutes. So I think we should probably wait for him to jumpstart our discussion today. I don't know. I don't want to, I can't get over yesterday's case, quite honestly. It's still living large in my mind, but I don't want to spoil it for everybody else. But I'll say hi to Aisha for two reasons. One, because she's doing teaching points today. And two, I'm just curious how you're feeling after the recovery process from Tansu's incredible case yesterday.
I legit was thinking about it for a few hours after. And then I kept reading about hyperferritinemia, and I was just trying to figure out what I missed personally when I was looking at the patient's information. But it was an amazing case. I actually had a dream last night about something about iron. Well, it was a nightmare, but
oh my God. Wow.
VMR woke up and I was like, oh no.
Man, wow. VMR making it into your dreams. That's another level
really
of dedication.
Just like Kirtan, it haunts me in my sleep.
I hope you should tell him that on WhatsApp. I think he'll really appreciate that comment.
Did you have time to reflect on it as well?
Yeah, too much time, unfortunately. It's been many hours, but yes. But speaking of haunting me in my sleep, Prof. Rez, I'm kidding. Hello, sweetest dreams, Prof. Rez.
Good morning.
How are you today?
I am doing well. Excited for today's case. Do we have a case presenter?
Yes. Yeah. Fantastic. John is back.
Hi.
Tell me again what your friends call you. I missed it.
No, Cloud. My middle name is Claudio.
Oh, I see.
John is such a unique name.
You know, I won't be presumptuous and say that that you think of me as a friend. So I'm going to work towards being able to call you what your friends call you, or you can give me permission to. I'm ready for it anytime.
Yeah, let's do it.
All right, you got it. Prof. Rez, I think you should jump in and tackle Cloud's first aliquot. How does that sound?
You just said you wouldn't call him or be presumptuous, and then you demonstrated presumptuality.
I think you didn't hear the part where he granted me permission to. How convenient. All right. I don't know what to call you anymore.
I'm gonna call you Romero. We're really close.
Yeah. All right. Here goes the hour.
Okay, so it away, before we start, just a trigger warning. This case does have some aspect of self-harm, so heads up. So to start, our chief complaint, our 39-year-old female came in with an altered mental status.
And Claudia, you have this already organized in aliquots. Is this our first pause?
Yes.
Okay, wonderful. I think we'll spend just a brief amount of time here because we've talked about altered mental status several times on these episodes. And what I'll say is the following. The tempo is going to be key. Qualifying the altered mental status as agitated, hyperactive, withdrawn is going to be helpful. And just knowing the patient's age, you have to entertain risky behavior. I'll leave it at that, Claudia. Looking forward to more information.
So moving on for our HPI, our history was obtained from her roommate. She was noted that she was not acting her normal self by her roommate. She reports that she had abrupt, sudden, jerky movements and was less interactive. The roommate shared that she had an appointment with her orthopedic doctor yesterday and was given some pain medication for her left knee. Her roommate expresses some concern that she may have taken too much medication this morning. For past medical history, she does have bipolar disorder, COPD, hypertension, osteoarthritis, hyperlipidemia. For medications, she's taken albuterol, aspirin, lithium, olanzapine, trazodone, and venlafaxine. Family history of paternal and maternal history of bipolar disorder, social history of previous attempts and suicide ideation, and she is allergic to Keppra. I'll leave it there.
Thanks, Claude. I think it's amazing what Prof. Rez predicted about how the accompanying features are going to help us a lot. And I think I'll tackle the HPI and leave the context, the medical history, et cetera, for Prof. Rez. And when we talk about acute altered mental status, which now Reza told us it would be important, and now we get that it's on the order of days. I have a personal update to the MIST mnemonic, M for metabolic, I for infection, S for structural, and T for toxin, which is that the following instinct, which is that I don't know how often M, metabolic, exists alone. How often is somebody hyponatremic alone without any other perturbants? How often somebody's hypercalcemic alone? How often somebody's uremic alone? Or how often somebody has liver injury alone? Or how often somebody has urinary retention alone? It's very, very common that the metabolic category is encased and exists as a complication of either an infection, a pneumonia with hyponatremia, or as a consequence of a toxin, say toxin plus rhabdo, so on and so forth. So for me, I really, really prioritize studying the I and the T much more so in most of my patients. And even if I find a metabolic cause, it's usually on account of another infection or toxin-mediated process. And I think that's the reflex to now acute altered mental status is no matter what metabolic causes get uncovered, I think we have to look for infections and toxins. And I think the question is, what do the other two data points that we have that she has jerky movements and that she received a pain medication from Ortho Clinic, what do they do for us? And of course, the pain medication prioritizes a toxin, a medication or toxin. And one could speculate on what that is, whether that's an opiate or a GABAergic agent like gabapentin. But those medications that possibility should be further reinforced by the jerky movements. So what do jerky movements mean in the context of encephalopathy? They could mean many things. They could mean a tremor. They could mean chorea. They could mean many things. But the most common finding you'll see in patients who are altered and have jerky movements is the presence of myoclonus, which really, really catches people's eyes and catches non-medicine folks' eyes as the most abnormal thing. So for me, I'm starting to say, why is this young woman having altered mental status and myoclonus? And the question therefore is, what is the localizing value of myoclonus in the presence of altered mental status? And if you look very closely, you'll find an example of every single thing in MIST, M-I-S-T, in the world of myoclonus. However, there are two things that are hyper-represented. and that's autoimmune encephalitides. There are many autoimmune encephalitides that feature movement disorders. And here again, toxins, serotonin syndrome, gabapentin toxicity, antibiotic toxicity. So for me, there are two strong signals that a toxin, from the HPI alone, there are two strong signals that a toxin is at play. One is a report of exposure to medication. And whenever you use the word report, you have to qualify it. But then the report of myoclonus or myoclonus, which would prioritize autoimmune or toxin. So pretty worried that we're dealing with a toxidrome here. But of course, the eye is the other part of the mist that you never let go of. Other thoughts, Prof. Rez?
I love that approach, Rabih. And my this is what my teaching will be for this aliquot. If you ask the question, what's the difference between myoclonus and twitch? Myoclonus is really a movement disorder. Remember, the first step in identifying and making progress on any of these involuntary muscle contractions is framing it appropriately. Because the DDX is influenced by whether you say twitch, which is a fasciculation, myoclonus, a tremor, muscle cramp, or myochemia. Like all of these have a unique signature on the physical exam. And the main difference between a fasciculation, which is just superficial muscle fibers twitching involuntarily, and myoclonus is across the joint, a movement across the joint. And it's often described by the clinician as a jerky movement. And I loved how Rabih incorporated that into his approach to altered mental status. And what I'd like to focus on in the past medical history is two things. One is the medications the patient is receiving, which includes lithium and NSAIDs. And the other is the previous attempt at suicide. This is very important. Even if that history wasn't there, I would still be worried about excessive intake of some of these medications, especially with the foreground of myoclonus. So here's what I'd like to show you. I used to get so nervous about lithium toxicity because we don't see it often. Things, Rabih, I feel like we don't see often. Like there's things that we see every day and we understand every single nuance. Like, oh, why is the eosinophil count 500 if we're thinking about a bacteria? That can't be bacterial. But there's some stuff we don't see and we don't know the nuances. And we have to use prior cases and we have to dive deep into try to understanding them. And this is where we'll take you to our RLR website. So this is really what I would do. And Rabih, you can see this right now, the lithium toxicity. Okay, thank you. This is really what I would do in real life. This patient would be called out by the ED, much like Claudio said, altered mental status, myoclonus, history of suicidal attempts in the background of taking lithium. And I'd be like, oh wait, could this be lithium toxicity? And when you're approaching lithium toxicity, we actually have two figures here for it. One is, this is like a broad overview because you have to understand that lithium toxicity exists in two forms. It's either acute or chronic, but don't forget where the two marry each other, where you can have chronic with an acute component. So there's a lot of overlap. And it's really 4 organ systems. And the key to get chronic lithium toxicity is impaired kidney function. So you tell me the patient's taking NSAIDs, how many NSAIDs did they take? Did they have kidney injury from those NSAIDs? Did that then lead to the buildup of lithium that's now manifesting as lithium neurotoxicity? And these are the 4 organs that are at play. And depending on which organs at play will dictate whether you should be more concerned for acute and chronic. And I'm going to share an epic pearl with you because I think we discussed on one, I mean, yeah, we did case, and I'll tell you exactly which case. It was, oh, we don't have the case linked here, but on one of the cases, we discussed lithium toxicity. And Rabih, have you seen a patient with lithium toxicity?
I don't think so. Yeah,
you haven't? Okay,
no.
This thing is so striking. So you go in the room and this, like literally, there'll be these really abnormal jerks. And I've seen 2 cases so far. and altered, but just like shit. And it's really prominent neuro jerks that happen here. And so who's at risk? Someone who's taking lithium. That part, hopefully all of you would already know. And then why does it happen? It's because it's a narrow therapeutic index. And the maximum intracellular levels of lithium are in the brain and kidney. What are the two organs that are at hook here? The brain and the kidney. And it's this terrible thing where the kidney, when it gets impaired, it's like a vicious cycle, and the levels build up. This is the key you have to know. And this is the big pearl right here, is that the lithium levels don't correlate with toxicity, especially in the acute setting. And that when you're checking lithium levels, the last place for lithium to leave is the CNS. It doesn't involve the CNS early. It takes time to involve the CNS, so it takes time to leave the CNS. So you can't use the lithium level to correlate. I don't want to spend too much time here because it might not be the case, but this is really what I would do. I'd pull this up and I'd be like, okay, we have tremor, myoclonus. This patient's taking lithium. So definitely there's a concern for neurotoxicity. And I just have to be aware that the patient can have bradycardia, some EKG abnormalities, may have some kidney abnormalities. So I'll take it from there. And yeah, so that's really like how I'm thinking about this case, Claudio. And whenever you're at risk of one ingestion, know you're at risk of multiple ingestions. So looking for co-ingestions will be important. And yeah, and we're applying the sequence of events that maybe that medication she got for pain also worsened the kidney function. And yeah, what I'm just realizing, I don't want this to seem like we're diagnosing lithium toxicity just based on the, it's just the background data, folks. Just relax. We're going to get the physical exam and we're going to keep that TTX broad. It could be NMDA receptor encephalitis, who knows? But anyways, Claudio Romero, back to you, my friend.
That was great. That was cool. That was cool. Let's move on to the physical exam and vitals. So for temperature, she has a temperature of 37.5. Heart rate of 123, respiration rate of 20, a blood pressure of 142/86. And she is saturating at 95%. For general exam, she is agitated, looks ill appearing, but is in not any respiratory distress. Her mucous membranes are dry with no scleroicterus, no increased work of breathing, no crackles or wheezes are heard. Tachycardic with a regular rhythm, no murmurs or peripheral edema. Her abdomen is soft, non-tender, non-distended. Bowel sounds are present. Skin is warm and dry. For our neuro exam, she's ANO times 0. She is non-responsive. Her pupils are equal, round, reactive to light and accommodation. Her oculocephalic reflexes are intact. Corneals are present. Will grimace to supraorbital ridge pressure. There's no flattening of nasolabial folds. Gag is intact. Her joints are stiff globally, limited range of motion, passive and active. Clonus is noted bilaterally on her lower extremities. No cogwheel rigidity appreciated. Sensation and coordination were not tested.
I'm actually going to pass the mic to Robbie because I just talked for 2 hours.
No, you didn't. Don't be silly. Come on. No, okay, I can start off, but I'll pass to you. I'll just say for the many of you who are IMGs or for students, rlrcpsolvers.com is behind the paywall, but you guys get 50% off with the coupon RLRIMG. So try it out if you're interested. Prof Rez, there's some really interesting but subtle things here, and I think when you see that heart rate, I mean, you probably will assume it's sinus. And I think, you really have to analyze the sinus tachycardia. It's very easy to sort of overlook that and be like, oh, that's probably not too surprising here in somebody who has dry mucous membranes. But in the world of toxidrome, and the toxidrome hypothesis is being built in the HPI and the past medical history, sinus tachycardia really is important to study. And the initial branch point is to try to say, is the sinus tachycardia as a result of a toxidrome causing increased sympathetic tone? Or is it as a result of a toxidrome exerting its anticholinergic effects? Like that's the initial branch point that you want to try to say. Is this sympathetic excess or is this parasympathetic deficiency as a simplistic approach? And the distinction between those two is best understood by where the sympathetic and parasympathetic systems do dissimilar things. So both of them will dilate the pupils, both sympathetic excess or parasympathetic deficiency. But what the anticholinergic effects will do is they'll dry the skin, and in stark contrast to sympathetic excess, which causes diaphoresis. And so here, in the face of that tachycardia, if you're invoking a sympathetic toxidrome, you might expect the patient not to be dry, but to actually have a decent amount of sweating. And the absence of sweating here makes you wonder, does this person have an anticholinergic toxidrome? That can occur from many, many situations, but also from the anticholinergic effects of another medication she's on, olanzapine. So that's one way that you can try to say, is this sympathetic excess or parasympathetic blockade? The other place is not accessible on the physical exam, but is accessible with a simple bedside test, which is the bladder scan. Because sympathetic excess, while it can cause urinary retention, it doesn't quite do it to the same level as anticholinergic toxicity. So here, I think in this patient, she might not be able to urinate because of this toxidrome, and getting a bladder scan is really, really important. The eyes can also, subtle clues about the eyes can also be helpful. So in a patient who has sympathetic toxicity or anticholinergic toxicity, in both patients, the pupils will be large. But if the pupils don't constrict, that suggests anticholinergic presence, because the anticholinergic toxidrome blocks the ability for the pupils to constrict. But in sympathetic excess, the sympathetic excess can be overcome by light. But in parasympathetic deficiency, the muscarinic tone is too low to be able to even overcome by light. So I would really be trying to do those things at the bedside, recognizing that patients don't necessarily read textbooks, but it would be important to try to say, am I building up a lot of clues for anticholinergic? And here the evidence for anticholinergic is in the skin. The evidence for sympathetic is that the pupils reacted to light, but you might be dealing with a milder anticholinergic effect. A bladder scan to look for urinary retention would help you tease those two things out. But that's one lens of this exam. I'm curious, Prof. Rez, if you had any other thoughts that crossed your mind.
No, I absolutely love that. Like those nuances in response to live, I've never heard that before. That's such an epic pearl. Nothing to add.
Cool. So let's go on with the first basic set of labs. Our WBC is 13.8, hemoglobin is 15, hematocrit at 46.6, platelets at 260, sodium at 142, potassium at 3.7, chloride at 108, BUN at 8, creatinine at 1, glucose at 93. I'll stop there for a little bit. And if anything you guys want to order while waiting.
Go for it, Prof. Rez.
This is helpful in that the patient seems stressed out because you have this elevated white count, you have a tachycardia, or they may be a bit hemoconcentrated. And so I think what we would want next is going to be a urine tox screen, a bladder scan per Rabih's incredible discussion in the previous aliquot. I would send a lithium level in this patient, and it would be helpful to have the rest of the comprehensive metabolic panel, including the liver chemistry test. I think, and an EKG is going to be important because you can have certain effects on the electrocardiogram, but that would be my initial start is EKG, UTOX, lithium level, and the rest of the comprehensive metabolic panel. Rabih, anything else you would get at this time?
No, I don't think so. I think that's an awesome start, honestly. Yeah. Yeah. I forgot about the EKG manifestations. You're right. I think those would be really, really telling. All
So
right,
the
Claude.
rest of
You
the
need me for
metabolic,
something, Robbie. You're not done with me yet.
so the rest of the metabolic panel were unremarkable. EKG is normal sinus rhythm. Urine drug test came back positive for cannabis, and our lithium level is 2.6.
I'm gonna pass the mic to Robbie. Can I just say something? I was about to type this in the chat. I love how no one laughs with us, man. Like everyone looks so serious on this. It's like,
You know, because you're Prof. Rez. Come on, you're a professor, of course. How would
the
someone?
jokes are not landing.
You know what? I think that's my primary role here is to laugh at your jokes while you wax poetically about the likely final diagnosis on aliquot 2, and then be like, oh wait, no, I didn't mean to do that. That's my role. Prof. Rez, I'm gonna have to pass the mic back to you, unfortunately, because I have no idea what a normal lithium level is. Do you know?
So this is okay. First of all, I think it's an interesting exercise to ask the question, what conditions in medicine travel together? Yeah, like patients can have as many diagnoses as possible, but what conditions, like when you see one, doesn't exclude another? And we can kick that off with tick-borne infections, nutritional deficiencies, psychiatric disorders, ingestion of toxins. But if I were to like teach this on rounds, I would say there's some conditions that travel together. If someone's at risk of one nutritional deficiency, they're at risk of another. If they're at risk of one STI, they're at risk of another. If they're at risk of one toxicity, they're probably at risk of another. So I think, Claudio, with this information, I'm very concerned for lithium toxicity. I can't exclude another toxicity. I would be curious to the prior creatinine level and because the BUN is slightly low, and you wonder about the patient's muscle mass and their intake. We don't have a weight, so I don't know what the kidney function is. But I would, at this point, I would be hydrating them. I would be talking to, depending on where you're located in the US, we have a poison control that we contact. There's no reason for me to know how to manage this. But if you're somewhere where it doesn't have that, then you do have to know how to manage this or learn how to manage it. We're as good as our environment. Put that on the tweet, Ravi, for later this morning. But Ravi, I honestly, what I would do is I would be like, is there something I'm not accounting for? This is compatible with lithium toxicity. I'm hydrating this patient. I'm probably getting psych and renal involved because I know that some of these patients need dialysis, and it's no joke. But I just don't want to anchor on this and make sure I'm not missing anything else. So I'm just curious from your lens, anything else that would be on the stuff that we need to do?
Yeah, you know, I think that these cases are very, very challenging, and I will just try to make an argument as to why, despite how critically ill this patient is, that I think you've probably reached a therapeutic threshold to start to address lithium toxicity, but you have to be open to the emergence of other things. And I think it just goes back down to the exam. So this person is obtunded, which means this is an emergency. You have to move very quickly. And so the next layer of information is to be like, is this person obtunded but protecting her airway? And when somebody is obtunded but protecting their airway, which Cloud's excellent exam tells us, you can then kind of slow down and say, okay, I'm going to now get diagnostic accuracy. And we've made both background and foreground arguments for the presence of a toxidrome in an at-risk patient, and now proven that there is a toxidrome at play with an elevated lithium level. So I think the real question is, I think there are two things that we could be sitting on. One is, in parallel, to ask ourselves, absent toxidromes, are there any other non-toxidrome emergencies that we should think about? And in a patient with coma, there's two considerations that you should keep in your back pocket at all times, which is that the person has basilar artery insufficiency or ischemia, one, which begets the question, should I do a CT-CTA? And the other is, does this person have non-convulsive status epilepticus? Like, those are the two things that should remain on your differential diagnosis until the patient's better, period. And And then the other thing is there another toxidrome? Well, if there is another toxidrome present, I think the only way you'll be able to detect its existence is through the emergence of symptoms despite treating this working diagnosis of a toxidrome. And if you ask yourself, are there any toxidromes that could be devastating at this juncture? And in the absence of an anion gap metabolic acidosis to suggest toxic alcohol poisoning, in the absence of QTC or QRS prolongation to suggest TCA poisoning. So all the things that could be happening now, there's no signal for them. So I think the hardest thing now, Prof. Rez, as the general internist, is if you're hitting the call button to renal and psych, and I would have a hard time in the ER about a CTA or an EEG, and quite frankly, in somebody this sick, even though the toxidrome hypothesis is 95%, I still haven't seen enough of these patients to be comfortable in this. So I probably would, if I'm by myself, get a CTA and put it to bed. It would be much easier if the renal or psych doctors told me that they're not convinced yet and need more data, and then we would get that test. So I'm convinced that we should start addressing lithium. I think the too scary diagnosis in a coma, you should always keep in your back pocket, and depending on what your resources are and what your own comfort is, deploying a CTA or asking for an EEG. And I'm pretty convinced that even if there is a toxidrome, another toxidrome, it is not exerting devastating effects, but pay attention to the EKG, trend it, pay attention to the anion gap, trend it. And if those start to change, then you can reassess is what I would be thinking if I'm trying to practice, like I'm actually taking care of this patient. Any thoughts on
Rabih,
that? Or?
Oh my gosh. It reminds me of the one pearl you shared on one of the RLR episodes for aortic dissection. You said that if you're diagnosing aortic dissection, 75% of the time you're thinking about aortic dissection, then you're under ordering the CTA, right? Because you're probably missing a bunch that you're just not sending the test for. And in this case, I love your point that like, if there's something catastrophic, our diagnostic threshold to do that is so much lower. Even if we miss 95 out of 100 times, we're wrong. But the 5, we want to capture the 5 because it could have devastating sequelae. Is that what you had said?
Yeah, 100%. Yeah, 100%. Yeah, exactly. You say it so much more eloquently and efficiently. I took like 10 minutes, and you're like, "Hey, Robbie." By the way, Aisha, this is how I get feedback. You know how you asked me for your feedback on your case discussion yesterday? Prof. Rez just gives it to me live. It's amazing for free. I'll say. Thank you, Prof.
Very naturally.
I know, right? That's why we call him Prof. Rez.
Prof. Rez, we do laugh at a lot of your jokes. You just don't see us laughing.
I don't see any smiles, Aisha. I'm going to challenge that.
I swear, I'm laughing after every aliquot.
All right, tell us more.
Robbie was right. A CT scan was ordered, but then it showed no evidence of acute intracranial abnormality. But instead of a CTA, an MRI was ordered. If I could share my screen real quick.
Let me make sure I made you co-host. I probably, no, you are. So you should be able to.
Here we go.
Uh-oh, Prof. Rez, we're going to have to interpret an MRI.
So yeah, axial cut T2 flare at the level of the lateral ventricles. This look nice, inviting, meringue-like wispy hyperintensities.
You know, I'll take a crack at it, Prof. Rez. I really don't have the expertise to understand this. I just see that there's hyperintensity in the white matter. Sorry about that. It seems to be posteriorly located in the occipital lobe. What I would be wondering is if this MRI was obtained with or without contrast.
Oh, I think it's without.
Without, yeah.
Without.
And yeah, so we don't know if it contrast enhanced or not, but I'd say that these are white matter. There seem to be white matter lesions in the posterior, in the occipital lobe. But I'm curious, Prof. Rez, what you thought when you saw this.
Yeah, this is fascinating. And Claudio, can you just share with us, like, where were you and the team when you got that lithium level back? Like what prompted an MRI for this patient? And then we can tackle this.
So I came in at around a week and she was in the ICU. She just wasn't getting better. An EEG was, after this, an EEG was she was hooked up to an EEG
Yeah.
just so we could figure out if she was having non-convulsive epilepsy. A lithium level was taken the week I wasn't there during her admission. And we decided to look for intracranial pathology because she just wasn't getting better.
So this is really important, everyone. Thank you for that information, Claudio. Like at time point 0, remember what Rabih said, like we're concerned for lithium toxicity. We're giving fluid and we expect the patient to get better with holding the lithium and giving fluid, but the patient didn't get better. So now you have to reframe this as a young woman with prior suicidal ideation on lithium and other antidepressants who's here with confusion and myoclonus with an elevated lithium level, but is not getting better on treatment. When you do that, then you go back to ordering more studies. But sometimes when you order studies out of context and out of a hypothesis-driven stimulus, it's really hard to interpret stuff. And I'm sure like Tiago will tell you this when it comes to a lot of the endocrine access that we order in the hospital for no apparent reason. You get an abdomen and you're like, what do we do? And most often it's like follow up outpatient and repeat the test. But now I don't have white matter lesions as my illness script in lithium toxicity. And furthermore, the patient's not getting better. So once again, what do I do in this context is I come to our RLR website and I pull it up, white matter disease. And you look at the non-inflammatory causes and you see there's stuff like heavy metal, methanol, but remember, we didn't have an anion gap acidosis. I will say one very important thing about these alcohols. Sometimes at time point 0, you actually don't have an anion gap because it's primarily the osmol before it's metabolized. So you have an osmolar gap, but as the osmol is being metabolized, the osmolar gap goes down and the anion gap emerges. So depending on when you actually order the test, it will be influential. I would definitely send a B12 in this patient. And I'm incorporating the myoclonus too. It would be really odd for cobalamin deficiency to have sort of myoclonus. She is in the right age for certain autoimmune diseases, but quite frankly, Rabih, I don't know how these inflammatory processes would put their imprint on the brain. And so rather than send all of this workup, which you can see we have like a bunch of stuff here, I would talk to I learned enough from Aaron that I know these lesions don't look like MS, but what I would do is I would talk to the neuroradiologist and ask them, what is their radiographic prioritized differential diagnosis based on these findings? I want to show you one more thing, because I think another key element in this case was the myoclonus. And I do have to say one thing, that just because you diagnose one condition, it doesn't mean you've ruled out another condition, meaning that this patient may have had lithium toxicity leading to myoclonus, but then there's a background of something else that is emerging. But this is our DDX or our schema for myoclonus. And it really, the center of it is metabolic, toxin, and meds. But if you go here for the structural stuff, there's a few other things that can cause myoclonus. So I would be overlapping these various Venn diagrams, but ultimately I would talk to a neuroradiologist and ask them for their prioritized CDX. I would send an ANA and I would think about autoimmune workups. I'd be considering if I need to get an LP and to make more headway on whether there's CNS inflammation, because notoriously CNS inflammation doesn't leave any kind of imprint systemically. So you can have a lot of inflammation in the brain without anything happening systemically. Before we move on, I would love to hear Rabih's thoughts on this.
Oh no, I completely agree with you, Prof. Rez. I'm really curious because I'm no expert. I want to make sure that we're solving the right problem. So there's no way that in real life that this would involve my read of the MRI. So I'm curious, Claude, what was the official read of the MRI? What did y'all?
Well, the official read was basically PRES, posterior reversible encephalopathy syndrome.
Yeah.
The cute thing with PRES is it's not all the time posterior, it's not all the time
Yeah.
reversible. Sometimes encephalopathy can't be a part of it. So if you can recall the picture, it's not like a stroke where you have like really strong defined watershed lines of bleeding, more like that inviting cottony wispy meringue like white structures. It can also be viewed as a alternative to hypertensive emergency urgency, where you have the loss of the brain's function to auto-regulate blood control. It also can be seen in patients who have autoimmune disease, where T cell activation destroys the blood-brain barrier and furthermore disrupts the brain's ability to auto-regulate blood pressure. But the funny thing about this case was that Prof. Rez did everything right. We did everything what he said. We aggressively hydrated. We gave him medication. We gave her medication for serotonin syndrome. She wasn't getting better after 4 days. And then the intensivist was like, you know what, let's switch to dantrolene. She got better right after. So everyone was thinking, wait, is it serotonin syndrome? Is it NMS? What's going on here? After a few days, she still wasn't getting better. She still showed signs of lithium toxicity, even though her lithium levels did come down. We took brain imaging. We saw PRES after the MRI. We did consult renal for renal replacement therapy. They were like, probably not yet, but we might get there. Then after a while, the whole team sat down, and then the neurointensivist diagnosed her with silent. So it's a syndrome of irreversible lithium effectuated neurotoxicity. So even though after all of the lithium is out of her body, the damage of lithium toxicity is still present. But eventually she did pull through after like 3-4 weeks in the ICU, and then she was slightly back to baseline.
A really, really unfortunate sequence of events, but I'm glad that you mentioned that she eventually got better. You know, I know Prof. Rez taught me about silent, and he did an amazing schema and video on this actually for RLR CP solvers. Prof. Rez, what do you please enlighten us?
Well, thank you so much, Robbie. You know what's so interesting? I literally at UCLA just discussed an unknown, and there was PRES. And when you showed that picture, first of all, Claudia, your illness script for PRES is so amazing. Like the way you taught it, it's really like, I felt like you just summarized everything I read in Up to Date just 2 days ago in like 1 minute. So well done, my friend. And really, Robbie, like if I'm being honest, when I saw that, I was like, oh, this looks like PRES. And I guess PRES is like one of those things. And the reason I said that was based on the location, but one of those things that is often just another finding. Like, what do I mean by that? It's like when you have hyponatremia, iron deficiency, anemia, SIADH, it's just another one of those. So, and I wonder if like lithium itself can make the vessels a little bit more permeable to leakage out, because what we're seeing is literally edema. It's like the vessels are leaky because either you have too much pressure or there's some med that's causing those vessels to be leaky. But I think, and here, I have to just share one more thing. Sorry, guys, I keep sharing stuff with you, but actually, I'm not sorry. You're welcome. But here it is. So here's Glass Health. Highly recommend you use it. Literally, I just typed in my lithium toxicity and right here, silent. But it goes back to what I said, that the pearl, like it takes the longest for lithium to enter the CNS, and that's why it's part of chronic toxicity. And it's the one location that, despite the serum levels being normal, it's the longest to come out of the CNS. And that's really what seems to be at play here. So if we can do a quick cognitive autopsy, the patient was either not getting better because we had the wrong diagnosis, or not getting better because they had end stage diagnosis of what we considered. Really interesting case. And I'm glad she got better eventually. And here's the DDX. The thing that NMS, and that didn't really cross our minds, because every disease has like a different way of presenting, early, late, but it didn't cross our mind because the patient didn't have fever, rigidity, we didn't have a CK. Serotonin syndrome is fair game, especially with the myoclonus. But again, that is more, I believe, fast on, fast off. So just wouldn't be consistent with the, but these are the ones that just, go together. Back to you, Ravi.
Yeah, no, I think this is such a humbling case. And at the end of the day, just the age of the patient is a clue to the presence of a toxidrome. And then the myoclonus further supports that. And then when you got the background history of meds that are implicated in many toxidromes, and then if you ask yourself, what did it probably turn out to be? Was it sympathetic or anticholinergic? And lithium is on that medication list that causes a lot of sympathetic toxicity side effects. And if you look at some of the complications of sympathetic toxicity, the complications of it are that the underlying causes devastation, right? Like the underlying disease, but there are some non-specific complications of the systemic sympathetic toxicity itself, including Takotsubo's cardiomyopathy, bowel obstruction, and of course, PRES. And so here, I think the sequence of events is probably that this patient had lithium-induced sympathetic excess with disproportionate effects on the brain. And unfortunately, that resulted in both PRES and silent. Which is fascinating, highly educational, and ultimately, thankfully, due to very patient-centered care, she seemed to have done very well. I'm curious, Claude, what was your reflection and experience learning from this patient and sharing her learning with us today?
I really hold the intensivist in high regard because they always seem to know what's going on. But with this case, they were like, what's going on? They had a difficult time, but it was nice to see them go through the motions and talk to people. I mean, ask for consults. They curbside a lot of other specialists, and then they started going through the motions and arriving at the diagnosis. But then, there was an old saying I remember hearing where medicine is the art of abusing the patient while the patient heals himself. It's sort of kind of like this, because although we just kept her afloat while she started to get better on her own, like we aggressively hydrated, we made sure her BP was good, her sodium was in tight control, made sure she wasn't convulsing or having epilepsy, and then she got better on her own. Yeah,
I love that. I love that. That's such wisdom, and I love that you said you keep the patient afloat. That's all you're doing. You're just providing some supportive therapy while the patient recovers. I think that's such a fantastic reflection. Well, you've now presented us two bamboozling neurological cases. Are you sure you don't want to be a neurologist, my friend?
I just enjoy medicine in general. I think I have medical Stockholm syndrome. So where I am, I'm like, oh, that's cool. Oh, that's cool.
Well, that's a sign of a general internist, my friend. I hope you'll join the club and that you'll keep laughing at all of Prof. Red's jokes well into your healthy internal medicine career. All right, Aisha, take us home, please.
John, that was such an amazing case and amazing discussion and really funny jokes, Prof. Rez. Just letting you know, we're very funny. Okay, so we started off with a 39-year-old female with altered mental status who wasn't acting her normal self. She was less interactive with jerky movements. So start out in the beginning, we're going to be thinking about missed mnemonic, which is metabolic, which could be due to hypo or hypernatremia, hypo or hyperglycemia, increased BUN creatinine. We can think of that because she's also taking lithium and NSAIDs causing further kidney damage that could increase her BUN or creatinine. Infections that could be either extra or intracranial infections, structural causes such as a subdural hemorrhage, or toxins. So toxins in this case are very important, taking into consideration her young age. So infections and toxins would take priority in the differentials. And depending on the patient's age, we also have to consider any risky behavior that is either reported or not reported at all, and also consider her other exposure medications. So for her, she was taking olanzapine, venlafaxine, trazodone, and NSAID. So also consider those and if they can exacerbate any toxicity from any other drug. So at this point, we were stressing about lithium toxicity, even though that might not be the final diagnosis. At this point, that was explaining some of the symptoms. So when we think about lithium toxicity, we have to consider other medications that the patient was taking. So NSAIDs, are they taking ACE inhibitors, diuretics? And because lithium has a very narrow therapeutic index, maximum levels can accumulate in the kidney and the brain. But in the brain, because in the acute settings, it doesn't accumulate in the brain yet, there can be levels in the CNS that are found later on, even if the lithium toxicity, levels are normal, because it takes the longest to leave the CNS. And as Prof. mentioned, when a patient is at risk of one ingestion, we should always be looking for other ingestions causing the other symptoms. So it could be the coma that other ingestions could be causing, or any other pulmonary symptoms that could be caused by other ingestions as well. So for pupil findings, we have to consider is this due to a sympathetic axis or parasympathetic deficiency. And if there is any urine retention, we have to think about it if it's sympathetic axis, or we can also do a bladder scan to figure out if it was due to an anticholinergic toxicity, because that was also one of the differentials at this point. And if a patient is at risk of one thing, consider and take into consideration that the patient might be at risk of other similar toxins or infections or any nutritional deficiencies. If there's one, there'll be more of them. And when a patient is in coma and the initial diagnosis, so in our patient, we thought it was lithium toxicity, it's not improving after the lithium levels are determined. If they're still not improving, consider two things. So either it could be basilar artery ischemia. If that's the case, do a CTA, or it could be non-convulsive status epilepticus. And in that case, do an EEG. Or is there, again, another tox syndrome present? If the symptoms still persist after the primary tox ingestion has been resolved or not resolved. And for this patient, we had some MRI findings. So when we have MRI findings, you have to prioritize the diagnosis. Ask the radiology, what differential diagnosis would you prioritize based off the radiological findings? And we found out that there is a possibility of PRESS syndrome, posterior reversible encephalopathy syndrome, which is characterized by headache, seizures, altered mental status, which is what our patient came with, and visual loss. And on MRI findings, there's white matter vasogenic edema, which affects the posterior occipital and the parietal lobes of the brain. And in this patient, you have to remember that lithium is always last to leave. So the patient could still have remaining lithium levels in the CNS, even if they're normal. And that's silent syndrome, which is the syndrome of irreversible lithium neurotoxicity, which might be causing the neuro symptoms because, again, lithium is last to leave the CNS. And yeah, amazing case. Thank you so much for the discussion.
Just like Ravi is last to leave the soccer field. Ayesha, great job. That was an epic teaching. Leave you all with that final laughter. But Prof. Ravi, anything to conclude with?
No, Prof. Reza, I know you couldn't make it yesterday, but Aisha had an amazing discussion for a fantastic case and crushed it again today with such amazing teaching points. Thank you to you, Aisha, for that. Thank you, Claude, for an amazing case. And Francisco, you did it. You did it. Awesome job with describing and excited to see you all. Well, sorry, tomorrow is a CP Solvers Academy Day. We'll be talking about a crazy EKG, but I think we're back on Sunday with student VMR. So if you're able to make it, we hope to see you there. Bye, y'all. Happy Friday.